This afternoon, we start the pilots, and the first pilot we're going to start with today is the comorbidities pilot. In the studio with me is Professor Dr. Josep Redon, Director and Head of the Institute of Medicine, Clínico University of Valencia, and joining us live from Spain is Dr. José Ramón Navarro from the Instituto Tecnológico de Informática. Gentlemen, the floor is yours, and I'll be back for the Q&A. Thank you.
Thank you very much. And is devoted to the comorbidities, the importance of comorbidities in chronic diseases. In the next slide, you will see which are the partners that are involved today in this pilot. It's ITI, it's Philips, it's Optimedis, it's INCLIVA, it's also Atos. Why the clustering on chronic diseases? In the next slide, you will see what is the impact of the cost of health in Europe, according to the GDP. According to the GDP, approximately 8 or 9% as an average correspond to healthcare, but 75% of this budget is devoted for chronic diseases. And the worst is that it is expected that increases over the years, mainly for long-term care. Why? In the next slide, you will see what is the changes in demographics in Europe. You will see how from 2016 to 2050 and 60, the pyramid of the population change. And there is a lot of people with more than 50 and 60 years old. And in the next slide, trying to check and to assess what is the impact of these diseases in healthcare, the group risk stratification demonstrated, like as you see, that the blue and the green bars are really account more than 50% of all the population. Then with this, and the next slide, we try to apply the techniques using big data and artificial intelligence in obtaining a better stratification of risk. For what? If we obtain a better stratification of risk, we can obtain much better impact that personalizes more the approach of the treatment of patients. And for that, next slide, you will see a summary, graphic summary of the pilot. First of all, we use the big data to obtain it in a large population, and we try to perform the best of our actions in order that to achieve and obtain the maximal benefits. These after need to be treated in a technique and using artificial intelligence in order to achieve what is the clusters of these diseases and what is the impact of each of the clusters in morbidity and mortality. And at the same time, and in parallel, we also try to assess what is the optimal, if the patients are receiving the optimal treatment or not. With all this together, we develop some devices. We develop some tools that the primary care physicians and the specialists can use at the time to assess the risk, not only of these diseases, chronic diseases, if not the cluster of the chronic diseases. And for that, we develop one app and one dashboard. And today, we are going to present you several of these data and also the validation of these tools that we have developed. In the next slide, the first that you will see are what are the challenges that we are going to address. The first challenges is the problem that we have for handling the data are big amount of data. It is, in this case, one database for close to 4 million of subjects obtained from the community. And in this, we need to treat according to the GDPR that has been commented this morning. And then we obtain the data, pseudonymize it, but also we anonymize them to work in that. And also develop in the next slide that you will see one scheme on how was the management of this database. The database was in our institution, and all the partners can access the database, but not can take out information. There is a front end in which there is a cooperation that the partners can work, but the data is still in our institution. In the next slide, of course, come with the second challenge. The second challenge is to try to optimize or to obtain information about if the people is treated in that following the recommendations and the regulation that has been established. And for this, we use one algorithms that was developed for Optimedis, that was the FORTA. If you move to the next slide, you will see there what is FORTA. FORTA tries to assess if the treatment one patient is receiving is according to the recommendations, because it tries to identify if it's not receiving what is necessary or if it's receiving medication that is insufficient for the treatment. And in this case, we apply this to people more than 65 years old, practically 1.5 million of people. And this was applied in all the Valencian community. You see in the next slide, you will see some of the impact that the points that you get. Points are negative always, with according to the number of patients in each of the healthcare, you can detect it. And then in this slide, you will see how to compare the number of subjects with the number of points obtained. And this was obtained for each of the more 800 healthcare centers that we have in our community. And in the next slide, you will see in a summary in which you consider what are the distribution according to the disease and according the management of the patients in terms of medication. The next, for sure, it's the calculation of the risk of hospitalization of the clusters and the risk of mortality and how the diseases are used. And my colleague, José Ramón from ITI, is going to speak all of you how this has been get.
Hello, I'm José Ramón, and now I'm going to explain the chronic disease clustering. First of all, this process has been divided in the process of modeling is divided in 3 stages. The first stage has consist of identifying the different significant clusters for each sex, age range, and up to a cardinality of 4 diseases for their respective KPI by using a divisive hierarchical risk clustering. At the second stage, we have identified the most relevant general clinical features for each cluster and compute the corresponding KPI risk for an individual for each concrete cluster. And finally, at the third stage, we provide information about the general individual KPI risk and the clinical and disease contribution to it. To do this, we have a data source that is related with electronic hospitalization rates of the Valencian community, with data that comes from 2012 to 2016. This includes all subjects from 24 years old, and this the information that is is related with which we work is the primary care and hospitals, and information about clinical features and biochemistry. The corresponding KPIs are mortality and hospitalization, and the table that is on the right represents on the one hand the division by what is sex, age range. These are 19 diseases in which we are interested when we create different comorbidity groups. and then we have the corresponding clinical features that we are going to use to create the corresponding models as explanatory variables and the 2 KPIs of interest in the project. Then the process, in summary, consists of first age and sex segmentation, compute the hospitalization and mortality risk for the comorbidity groups that has a minimum of 30 individuals, and calculate and also calculate previously what is the corresponding comorbidity groups from 2 up to 4 diseases. To do this, we have the possibility to work with the corresponding data set, and we have used machine learning algorithms and the corresponding explanatory variables explained before to obtain the corresponding KPI models based on classifiers that offer us the opportunity to know what are the risks for a individual. As we are interested also in the explainability of the model, we have worked with decision trees that allow us to offer this explainability. And the example shown in the corresponding slide shows us a decision tree for death risk for a man from 55 to 69 years old that has a heart failure. As you can observe, the final nodes represent each individual belongs to a final node, and the color, the blue color, represent a higher risk, and the red color a lower risk. This is another example for hospitalization risk for a man with 85 years old and that has atrial fibrillation. Then, with all this information and all this model, we have created 2 different applications. On the first application consists of a mobile phone that for the patients that I want to show you in a little video. First of all, we select the gender. After we select the age and then the corresponding comorbidity group. Then we are going to obtain, we are asking for the corresponding clinical features for the individual, and then we are going to obtain the corresponding hospitalization and mortality risk for the patient and the general. And finally, we can obtain more concrete information about the corresponding risk. The second application that I want to show you now is the next one. This is the dashboard. At the dashboard, we can observe, like, for example, you can study the distribution of the risk, the 2 risks of interest in the population. We can find in an easy way the risk, the comorbidity with a higher risk or with a great population. And also you can observe, like, for example, you can study a given that a comorbidity group from for example, 2 diseases, the transition to other diseases. In the example, you can observe, like, as greater was the circle, greater will be the population in the corresponding group, and as darker was the way, greater will be the number of people that come from one state to the other. And next, I pass the word to Dr. Josep Redon.
Professor, in the last 2 minutes to close, what are the results you're getting?
Well, I will show you some of course, a very, very small piece of the results. And you will see in this slide, you will see what are the 25 more frequent chronic diseases that we detected in our population. If we move, this is the number of clusters that has been developed for the risk of mortality or risk of hospitalization. And on top of this amount, you will see the number of diseases that you have in each of the clusters, the distribution. And if you move, then, for example, if we get heart failure, these are the most frequent clusters in diseases that are in the clusters of heart failure. But there are more than 100 diseases and more than 100 clusters of these diseases. Right. And if you go ahead, for example, you get one cluster. This is patients with heart failure, diabetes, hypertension, and atrial fibrillation. Right. If you move, you will see what is the risk in the last column, the total risk. Yeah. But the amount of risk of each of the elements, you will see distributed there. Then it is one way that the physician have one idea what is the more important of the diseases in the cluster in turn to produce more risk of develop hospitalization or mortality. And then the patients need to be treated according to this, that focus in more those that produce the greater impact. Right. If you move to the next one, these are, of course, we have strengths, but also we have limitation. Yeah. A limitation is that the risk when you increases much more the number of clusters, more than 5 or 6, the variability that you can find is really high. Wow. And then if you move, we try to validate this. And to validate this, what we do is to divide all the population, the 4 millions, in two sets, yeah. 70% as a train and 30% as a test. And then we try to see what is the congruence in between the values of the clusters in the two ones. Right. Then with this, we believe that this will be a very nice tool, but not only the nice tool that we have developed, but also we'll learn a lot about the management of data, of big data and artificial intelligence, but achieve better results in the future, mainly in the field of chronic non-communicable diseases.
Fantastic. Thank you so much for being here, and thank you to you for joining us. Okay. Our next session will start shortly. Thank you.